Okay, good morning, everyone, and assalamu alaikum. Today, we will discuss about carcinoma breast. Now, this has been quite a long time after I'm having this class. I was quite busy with a lot of things, still busy, but I tried to take this class because the recent prof exam is quite near, and a lot of people have been asking me that to take a few classes, especially on the long cases. And I think the carcinoma breast is a very prototype long case and very it's a good case to discuss if you want to learn about long cases. So let's start. So always, this is one of my favorite quotes. Remember this, that always listen to the patient. They might be telling you the diagnosis. So listening to the patient is of utmost importance because the patient is always trying hard to make sure that you get the diagnosis right. So if you listen to the patient and ask him the right questions, you'll get the diagnosis. Now, approach is very, very important. Most of the times, you must remember that first thing the patient looks at is your attire or your get-up, your dressing. So it's very important that you have a respectable clothing, which then patient gains confidence. Don't wear dresses like this, which makes you like as if you're from the modeling school, not medical school. So, approach to history taking. The first and the most important thing is the consent. How to take the consent? You ask the patient that Assalamu alaikum, I am one of the examiners and I've been asked to take a history, or I'll talk about the problem you're having. If you feel any discomfort, please tell me. এটা বাংলায় বললে এভাবে বলা যায় যে আসসালামু আলাইকুম, আমি একজন এক্সামিনি অথবা একজন পরীক্ষার্থী, আপনার সমস্যাটা সম্বন্ধে কথা বলতে এসেছি, কোনো সমস্যা হলে বলবেন, something like that. Maintenance of privacy, very, very important, especially if this is a female patient. If you're examining the breast, must talk about privacy. You must assure the patient that her privacy will be maintained, her dignity will be maintained. Because if the patient does not see those privacies maintained, then he will be very, very uncomfortable. Make sure the patient is as comfortable as possible. Summarize each stage of the history taking, meaning when you have taken the history of the lump, you tell the patient যে আচ্ছা ঠিক আছে আপনার তাহলে এরকম একটা চাকা পাওয়া যাচ্ছে, 6 মাস ধরে পাওয়া যাচ্ছে এবং এটা খুব তাড়াতাড়ি বড় হয়ে যাচ্ছে. Ask the patient if these informations are correct or not. Involve the patient. Involve the patient in the history taking process. Make sure you let the patient talk as much as possible. Don't stop her. A female attendant, especially if you are a male doctor, a female attendant is a must. You must talk about a female attendant during the exam. Components of history taking. Now, as we all know, the first thing is patient profile or the particulars of the patient, where you talk about the patient's name, age, sex, address, and etc. Chief complaints, you talk about what are the main problems the patient is having or why the patient has come to the hospital today. History of presenting illness, here we elaborate the chief complaints in details and any other inquiries that we might have about those problems. Past medical history, the relevant medical history that should be taken. For example, if the patient is having some sort of jaundice, you take the history of whether she had any previous history of any jaundice, whether the patient has taken any medications, because there are hepatotoxic drugs which may cause jaundice. Family history. Breast cancer is a great example of this because almost all cancers, especially breast cancer, runs in the family. If the mother has breast cancer, there is always a chance that the daughter may have breast cancer in the future. Socioeconomic history, very, very important. And then systemic reviews. We will discuss it in details. Patient profile, we know all about this, but most important are age. Usually, the patients above the age of 40, more commonly above the age of 50, they are prone to have malignancies or breast cancers. Female Of course, female breast cancer is more common than male. Males do have breast cancer, but in rare occasions. Marital status, why this is important? Because those who has children are less prone to breast cancer, or pregnancy has a protective effect on breast cancer. So chief complaints. The first and the most important complaint that usually female with breast cancer comes is swelling, or sometimes you can say lump. Sometimes it may be a mass. Whatever is appropriate. All these terms may be used: a swelling, a lump, or a mass in the right or left breast. And then talk about the duration. It's very important. For example, a patient having a lump for 10 years is less chance that this will be a malignancy. But a patient who has been having a rapidly growing mass for, let's say, 3 months has a greater chance of a malignancy. Pain. Usually, breast cancer, there is no pain. Usually. But sometimes there may be pain, especially in advanced cases when the breast cancer, when the malignancy has invaded into any nerve or into the muscles or into the skin. Then there is a constant aching pain. Nipple discharge most of the times nipple discharge may not be present, but if it is present, usually it's bloody, blood stained nipple discharge. How can we write a history of present illness? For example, a patient is having a lump. So we start with this line that according to the statement of the patient, she is reasonably all right 3 months back. Then he noticed a lump in her right breast, which is rapidly increasing in size. There may or may not be any association with pain. If there is pain, talk about its relations with menstrual cycle. Because the commonest lump that a patient comes to the breast clinic is with fibrocystic disease. Fibrocystic disease. Now, in this fibrocystic disease, they may be painful. Usually their pain is related to the menstrual cycle. They will tell you that during menstruation or just before menstruation, the pain increases and then it goes down. So fibrocystic, so history of pain in relation to the menstrual cycle is very important. Nipple discharge, if there is any discharge, you should talk about it, whether it's blood stained or not. If you are suspicious that this may be a malignancy, then you should talk about sites of metastasis. For example, is there any pulmonary metastasis? Meaning, what are the symptoms of pulmonary metastasis? The patient may have cough, the patient may have hemoptysis, may have respiratory distress. There may be bony metastasis, meaning the patient may have bone pain. Hepatic metastasis is quite rare. I have never seen any patient with breast cancer with hepatic metastasis, but can happen. But you should take the history. It's very rare. Overall health of the patient is very important. Appetite, weakness, weight loss, bowel, bladder habit. These are the things you should talk about. So if a patient comes to you with a breast malignancy, is presenting illness, maybe something like this, but according to the statement of the patient, she was reasonably okay, was reasonably all right. About 6 months back, then he noticed a lump in her right breast, which was rapidly increasing in size, but painless. There is associated blood-stained nipple discharge. And patient also complains of occasional cough, which is blood-stained. Maybe, something like that. And overall health, you should also talk about whether the patient's appetite weakness or weight loss is there or not. Usually in breast malignancy, there is not much weight loss. You'll see weight loss, especially in carcinoma stomach, sometimes in carcinoma esophagus, but especially in carcinoma stomach. You look at the patient, you can say that this person is having some sort of malignant disease. There's significant weight loss in case of carcinoma stomach. Past medical history, very, very important. Breast-related previous history, what does that mean? For example, whether there's any previous history of lump. You will see sometimes A patient will come to you with a previous history of operation or previous history of surgery done in probably in a village setting where the patient may had a malignancy, but it was just local excision was done or inadequate excision was done. So breast related previous history is very, very important. Past hospitalization, past surgeries, radiation, very, very important. Another history is if the patient has if the patient has a malignancy in one breast, there is always another chance that there is another malignancy in the second breast. So they are very related. So you should always take the history of the opposite breast. Medications, very, very important. Oral contraceptive pills, hormone replacement therapies. Now, you should remember that the breast malignancies are estrogen dependent. That means that growth of breast malignancy is dependent on the hormone estrogen. So anything that increases the estrogen level over the body has a greater chance of breast malignancy. For example, oral contraceptive pills, hormone replacement therapy, they all contain different hormones, especially estrogen, and they always has a greater chance, these females who are having oral contraceptive pills or hormone replacement therapy for a long period of time, for example, greater than 5 years. It's not like you have one pill and you're going to have malignancy. It's not that. For example, the patient is having for 5 years, 6 years, long time, then there is a chance that the patient may have malignancy. Also, allergies and gynecological and obstetric history. We will discuss this. Family history, most important, as we have already discussed that almost all malignancies, especially breast cancer, has the family history is very important, especially the first degree relatives. Who are the first degree relatives? Mother, sister. Whether they have the history of breast or ovarian malignancies. Very important that you should take the history. Socioeconomic history. Now, smoking and drinking are quite uncommon in Bangladesh, but you should always take this history as well. Menstrual history, most important. Age of menarche, age of menopause. These are very, very important times. Why? Because from the age of menarche to the age of menopause, this is the time the patient is having high estrogen level in the body. As we have already discussed, the breast cancer is related to the estrogen. So, patient who has a longer time in between menarche and menopause, meaning patient who has early menarche and late menopause are more prone to breast cancer. Number of children, age of first pregnancy, lactation. Why these are important? Because breastfeeding and pregnancy are protective against breast cancer. Lactation or breastfeeding and pregnancy. These are protective against breast cancers. Immunization history you should also take, because sometimes you will see that you think that this patient has breast cancer, but in FNS you'll see it, ultimately that the patient has tuberculosis of breast, which is quite common in our country. So immunization history should be taken. The breast examination is one of the most important part, and very always the examiner will ask you to show how you have done the breast examinations. Very, very important. There are a lot of very nice videos in the YouTube. You can have a look at those videos. Inspection is done in these three positions. You look at the nipple, whether any nipple displacement is there, deviation is there, pseudo-orange appearance. Why this happens? Because of the subcutaneous lymphatic obstructions. What happens is if you look at the breast skin, it's something like this. And if this is, for example, let's say this is a sweat gland, right? The gland is something like this, right? And there are a lot of ducts over here. So when the patient has edema, in the subcutaneous edema, what happens? It becomes something like this, right? So there's always a dimpling here. So this is what is happening here. It looks like an orange peel, orange skin. So this is called pseudo-orange appearance. This is a sign of advanced malignancy. This is because of the obstruction of the subcutaneous lymphatics. Skin dimpling and puckering. These are very important findings, and this shows that this is an advanced cancer. Why this happens? Because of infiltration into the Ashley-Cooper's ligament. What happens is the breast is suspended by the Ashley-Cooper's ligament, right? Something like that. These are the Ashley-Cooper's ligament. Now, if there is a malignancy over here, what this will happen, what this will cause is there will be desmoplastic reaction or fibrosis of this Ashley-Cooper's ligament, and as a result, this part of the breast will be something like this. There will be a dimpling or puckering of that place. Nipple retraction, again, these are all again the same cause, when infiltration and fibrosis of the lactiferous ducts. If this is the nipple, and you'll see there is a duct over here, and if the malignancy involves the duct, and there will be desmoplastic reaction and fibrosis. As a result, it will draw in the nipple, something like this, right? It will pull the malignancy will pull anything that it attaches itself towards itself because of the desmoplastic reaction or fibrosis. Palpation, again, have a look at those. Palpation is better done in a 45-degree angle. What are the important things that we look for? The site. For example, if this is a breast, we want to see where is the lump. Is it in the upper outer quadrant? For example, let's say this is the axilla. So this is the upper outer quadrant in the right breast. Then we want to see the size of the lump, whether it is 2 centimeter, 3 centimeter, 4 centimeter, 5 centimeter, because on those numbers, the staging or the TNM staging depends. For example, if the lump is less than 2 centimeter, it is stage 1 disease or T1. If it is more than 5 centimeter, it's T3. So based on those numbers, the initial treatment will vary. Size we have checked. Shape is not very important. Overlying surface will be irregular, right? Or overlying skin, you have to check whether there's any pseudo-orange appearance, whether there's dimpling or puckering or not. Another thing, what you have to see, if this is the pectoralis major muscle, if this is the breast, if this is the lump, and if this is the breast, you want to check whether the lump is fixed to the pectoralis major muscle or not, or whether the lump is fixed to the skin or not. Because on those, if the lump is fixed to the skin, it becomes T4B. If it is fixed to the muscle, it becomes T4A. So these are very, very important findings. How do you record those findings? For example, there's a simple way of recording these things. You will find this in Hamilton Bailey, I think. For example, a patient has a lump over here. You record these findings. You record these findings so that you can check it. For example, sometimes the lump disappears after chemoradiotherapy. You will be in big trouble if you do not record it. Then there's no way of finding the lump. So these are the things that you have to record. Salient features. So a patient with breast malignancy may have a salient feature something like this. Mrs. X, 57 years, a housewife from Borishal, was admitted to this hospital with a rapidly growing painless lump in left breast. She also complains of dull aching pain and blood-stained nipple discharge. She has no metastatic features. On general examination, usually general examination, the patient is there's not much, there's usually no findings are there, but you may get some findings. For example, if there's a lymph node enlargement, or if there's been anemia, you can say that on general examination, the patient is anemic and anxious looking. On local examination, there is a lump in the upper outer quadrant of the right breast, which is about 5 centimeter in its longest dimensions, and it is fixed to the underlying muscles. This is how you write about salient features. Very short, make it short, as short as possible, but with all the information that you can provide. Then provisional diagnosis, differential diagnosis, investigations, confirmed diagnosis. So what should be the, for example, if the patient has a lump in, for example, let's say in the left breast, which is, let's say, about 2 centimeter, and there is some mobile lymph nodes. So it can be a carcinoma left breast T1N1M0 if you did not find any metastatic features or metastatic findings in the palpation. It is T1N0. I will discuss about the TNM staging. Or a little more information can be provided. For example, if the patient is postmenopausal, then you can say carcinoma of left breast is a postmenopausal woman with T2N2M0, something like that. So this is the staging. Manchester staging was quite popular previously, but nowadays TNM staging is more popular. So I would ask everyone to learn the TNM staging first. Then Manchester staging you can also learn. So TNM staging, TIS means it's tumor, carcinoma in situ. There is usually no palpable lump. T1 meaning the lump is less than 2 centimeter. T2, lump is 2 to 5 centimeter. T3, greater than 5 centimeter. Now remember, when it becomes T3, it becomes a locally advanced disease. This means this is locally advanced, meaning this becomes a stage 3 disease. Okay. And also T4, anything above T3 is locally advanced disease. T4 means involvement into the skin or the chest wall. Okay. N0 means no nodal metastasis. N1 means there is metastasis, but they're mobile. N2 means metastasis, they are fixed, the lymph nodes are fixed. N3 means ipsilateral supraclavicular lymph nodes. And M means metastasis. M0 means no metastasis. M1 means distant metastasis, maybe in the lung, in the bones. If there is any M, if there's M1, it is always stage 4 disease. It doesn't matter what is the T or what is the N. If it is T3 or N2, this means, and anything above means locally advanced disease. Less than T3 and M0 means early disease. This is not always accurate, but this is somehow you can just discuss whether the patient is locally advanced or not. This part is important. This we have already discussed. These are already discussed. This is already discussed, but this is the part I want to discuss. T4A means involvement of the chest wall. T4B means involvement of the skin. How? Maybe pudgy orange appearance, ulceration, infiltration. 4C means A and B together, and 4D means inflammatory cancer. And these are the things which is summarized over here. This means early cancer. This means locally advanced, and this means stage 4 disease. This is exactly what is written over here. You can check this out. Types of breast cancer, there are many types. You don't have to learn all of them. The most important is ductal carcinoma, invasive ductal carcinoma. This is the part. This is the part which is important. Invasive ductal carcinoma. This is the commonest one. Etiopathogenesis, not very important, but commonest is the sporadic cancer. This is always, you will rarely you'll see that there is any familial association, but the sporadic commonest cancer, that the sporadic cancer, that what happens, there may be familial association in 20 to 30%, and hereditary breast cancer in 5 to 10%, meaning they will have these genes, especially BRCA1 and BRCA2. BRCA probably means breast-related cancer antigen. You can check it out whether it's correct or not, but there's a lot of people that say it means breast-related cancer antigen. Again, the way we have showed you that how to record your findings. And the commonest site of breast cancer is the upper and outer quadrant, 60%. Investigations, whenever you are asked in the exam hall about the investigations of the carcinoma breast, always use this term, triple assessment, meaning 3 ways it is being assessed: the clinical, imaging, and then pathology. Clinically means we do the history and clinical examination, imaging, ultrasound and mammogram, and pathology meaning FNSC or core cut biopsy. Nowadays, core cut is more popular. Mammogram is very, very important, both for staging purpose, both for diagnosis and for screening purposes. Mammogram is usually done in females greater than 35 years, because below 35 years, the breast is dense. As a result, the mammogram is not a very good investigation, because it usually diagnoses malignancy in the form of density. For example, in case malignancy, if this is a breast, you'll see the malignancy will probably look like this. Now, if there is excessive density around it, high density, then sometimes the malignancy is very difficult to be evaluated by a mammogram. This is what happens in case of females, younger females below the age of 35 years. Because of their highly dense breast, a malignancy is not a good investigation to evaluate a malignant lump. But in case of elderly females, what happens is the density is low, so usually you can see the lump. Asymmetry, very important. You must compare the both breasts. Pleomorphic microcalcification. This happens more in breast cancers. Architectural distortion is always there in malignancy. This is very important. Stellate or spiculated appearance. This is what I have shown you. This stellate or spiculated, that means it looks like a thorn, something like this. Spiculated appearance in case of malignancy. BIRADS, this is breast imaging reporting and data system. Not very important in the undergrad level. Looks like a lot of writing. Don't worry about it. The easiest way to learn is 0, 1, 2. This means benign. 3, 4 means plus minus, suspicious, suspicion of malignancy. And 5, 6 means malignancy. Ultrasound should be done in females younger than 35 years. Malignant masses will appear as irregular margins and hypoequic. And another thing important here is solid or cystic lesions. Very good investigation to differentiate between solid and cystic lesions. FNSC, it's usually done with a 22 gauge needle, very narrow needle, and Usually it's not a good investigation because false negatives are high, inadequate specimen, and it cannot differentiate between in situ and invasive lesion. It also cannot evaluate the receptor status of the malignancy. That's why more popular is core needle biopsy. It's done with a 14 or a wider needle or a true cut needle, lower false negatives, adequate samples. It can differentiate between in situ and invasive malignancy. It can confirm the receptor status. In case if it's a non, this is not very important, but should learn this, that if it's a lump is not palpable, then it can be done image guided biopsy, ultrasound guided FNSC, or stereotactic needle biopsy in form of mammogram guided biopsy. Sentinel lymph node biopsy. How it is done? There are two types of dyes that are injected into the tumor. One is a colored dye and another is a radioactive dye. So what happens is, this is actually done to find out if the lymph nodes are involved or not. For example, if there is a lump over here, you inject some dye over here, both blue dyes and the radioactive dye. So what will happen is, this will go over here, right? Sentinel lymph node means the first lymph node that is being drained. So when it goes over there, but you don't know where the lymph node is, then you check with the Geiger counter, the portable gamma camera, and you see there is a lymph node over here. You give an incision over here, and then you see the blue dye. So then you extract or other investigations, and if you see that it is involved, then you do a axillary clearance. Indication, early cancers. This is the thing you should remember. Indication is early cancers. Contraindications are inflammatory breast cancer. Most importantly, palpable axillary lymph nodes. If palpable axillary lymph nodes are present, then it's a contraindication to do sentinel lymph node biopsy because it's no longer necessary. These are other investigations, the chest X-ray, CT scan, abdomen, to check out. This is bone scan. This is important to check for any bony metastasis. Management, surgery, radiotherapy, chemotherapy, hormonal therapy. These are the four modes of treatment. Surgery can be curative, palliative. Radiotherapy, different forms of radiotherapy are present. This may look a little complicated, but let's make things simple. If it is an early breast cancer, meaning stage 1 or stage 2 disease, you go for surgery. If it is locally advanced, then that means stage 3. You go for neoadjuvant chemotherapy. And if there is metastasis present, then you go for palliative. So what happens in case of early breast cancer, if it is less than 2 centimeters size, it's small, you can go for breast conserving surgery. Now, at undergrad level, just remember this term, breast conserving surgery. Further is no longer necessary. Breast conserving surgeries can be done, which is now also being done in Bangladesh in a lot of centers. And stage 2 and above, a surgery needed, which is in the form of modified radical mastectomy. So what happens in case of modified radical mastectomy? If this is the breast, if this is the nipple areola, and if this is a tumor, and if this is the pectoralis major muscle, in case of radical mastectomy, what you do is you remove everything. You remove the nipple areola, the lump, and the pectoralis major muscle, everything. But in case of modified radical mastectomy, you only remove this portion, but the pectoralis major muscle is not removed. And this is the commonest surgery nowadays done, modified radical mastectomy. And yes, always the axillary clearance is being done. What do we mean by axillary clearance? That means all the axillary fat and lymph nodes are removed. All the axillary lymph nodes and fat are removed. This means axillary clearance. At least 15 lymph nodes. The number may vary. Sometimes it varies. Some people say it's less than that. Some say more than that. But at least 15 lymph nodes, 15 to 20 lymph nodes should be removed for axillary clearance. There are other terms that are also being used, that axillary dissection. But axillary clearance is the term that you should use. That in case of modified radical mastectomy, what we remove is the breast, the overlying skin, the nipple and areola, the tumor, together with axillary clearance. Okay. Other terms are like axillary dissection and axillary sampling. Axillary dissection means, if you remember, a lot of information to be talked about. There are three sides of lymph nodes. If this is the pectoralis minor muscle, the lymph nodes that are lateral to the pectoralis minor, these are one, given as one. Behind, these are given as two. And we are medial to this lymph node, these are three. So when you remove one and two, this is called axillary dissection. When you remove all of them, this is called axillary clearance. And when you just take one lymph node from each side, or sometimes two, that's called axillary sampling. I don't think you have to remember all these things in undergrad level. Undergrad level, what you are going to tell everyone is that if it is an early cancer, that means stage 1 and 2, you go for surgery. And surgery is modified radical mastectomy. That's it. If it is locally advanced cancer, that is stage 3, meaning the tumor may be more than 5 centimeter, or a patient may have a fixed lymph nodes, or the tumor may be fixed to the overlying skin or the underlying muscles. In these cases, you'll first go for neoadjuvant chemotherapy, downstage the disease, make it operable, and then you do the surgery. And if there is metastasis, then you again go for palliative chemoradiotherapy, because in case of metastasis, there will no longer be any curative surgery. Everything related to metastatic disease is palliative. Again, these are the things that's written over here. Locally advanced breast cancer, that means T3N1M0, meaning the tumor is greater than 5 centimeters. Or T4, meaning the tumor has invaded into the chest wall or into the skin. N3 and N2 means either fixed axial lymph nodes or palpable ipsilateral supraclavicular lymph nodes. Inflammatory breast cancer is T4D. All these are classified as locally advanced breast cancer. They are all stage 3. There's different ways. You don't have to be confused with all these things. This lecture was probably written for somebody, a more advanced audience, but don't have to remember anything about this. If it is operable, if you think it is operable, then you can go for surgery. But in your case, you'll always say, if it's a locally advanced breast cancer, I will go for neoadjuvant chemoradiotherapy. Downstage the disease, and then we go for surgery. Okay. In case of inoperable cancer, again, we go for neoadjuvant chemotherapy to make it operable. Regional control is important, hence to improve patients' quality of life. This is called neoadjuvant chemotherapy, then surgery. And again, the patient may need chemoradiotherapy or hormone therapy. Why do we go for neoadjuvant chemotherapy? To make the tumor operable, to assess the response to chemotherapy. What are the prognostic factors? Nodal status, most important. Tumor size. For your case, nodal status and tumor size. These are the most important prognostic factor. We use the Nottingham Prognostic Index, but this is the formula. The tumor size, the nodal status, and the grading. It's all written over here. You don't have to learn this, but just remember that there is an index called Nottingham Prognostic Index, which is important to check for the prognosis and the 5-year survival. For example, if the Nottingham prognostic index is somewhere between 2 and 2.4. There's excellent survival rate of 93%, but it is less, it is more than 5.4, poor prognosis, less chance of 5 year survival. Adjuvant chemotherapy, you don't have to learn all this, but if you're interested, you can remember cyclophosphamide, methotrexate, and anthracyclines and taxanes. These are used for chemotherapy. If you don't remember, I don't think people will mind, but knowing one or two is good. Simple, quite simple. Hormone therapy. What are the hormone therapies that are being used? Always remember, it must be ER/PR positive. Otherwise, there's no point of using those. Tamoxifen is a estrogen receptor modulator, not exactly a blocker, it's a modulator. This is being used for about 5 years, which has a grave side effect of endometrial cancer and thromboembolism. Just remember the name, that's good enough at undergrad level, the tamoxifen, estrogen receptor modulator, or you can say estrogen receptor blocker. Here, selective estrogen receptor modulators, tamoxifen, aromatase inhibitor, anastrozole. Don't have to remember the rest. Remember this one. This is the one that is important. Hormone therapy, the HER2 receptor. Any patient who has human epidermal growth factor receptor 2, the patient can be given Herceptin or trastuzumab. And then radiotherapy, not very important. Follow-up, this is very important. Follow-up is, they have different protocols in different hospitals, but first, every 4 months in the first 2 years, then 6 months in 3 and 5 years, then 12 months thereafter. What we follow is 3 months in the first year, then 6 monthly in second and third year, then 12 monthly in fourth and fifth year, and then the patient can have then patient is followed up in irregular intervals, not very important. So these are protocols, it may vary, but just remember that it's something like this. So thank you for your attention. Thank you, guys. Next week we will try to discuss about something else. If you have any comments, if you have any preference, feel free to tell me.